Good morning, everyone, and welcome to this on-demand conference in which we talk about all the most important factors that influence the maintenance of hard and soft peri-implant tissues and the achievement of predictable marginal bone remodeling. All this according to the clinical experience of the Vericat Implantology team. First of all, I would like to introduce you our team. We work in Spain, in Valencia, but also in Madrid. And our most distinctive feature is our exclusive dedication to oral surgery and implantology. Therefore, based on our own clinical experience and the specificity of our practice, I would like to start by sharing with you the main pillars of our philosophy, the key points in our daily workflow. First of all, the focus of each surgical treatment always has one main objective, at least from the biological point of view. That is the peri-implant tissue maintenance and the predictable short, medium and long-term marginal bone remodeling. We know that implant survival rates in the current scientific literature are extremely high, so our concern is no longer focused on the osseointegration phase, but rather on the prevention of those marginal bone resorptions and those potentially associated processes of peri-implantitis. And of course, the preservation of a stable and healthy soft tissue is as important as hard tissue preservation due to its protective effect on the underlying bone and the enormous aesthetic repercussions that it entails, especially in front areas. Secondly, immediate loading constitutes a key protocol in our daily practice. It's carried out systematically from full arch to single implant rehabilitations, also in posterior regions if demanded by the patient. And well, I just use the generic expression of immediate loading, referring to the concept of a fixed provisionalization on recently placed implants without distinguishing in this context immediate function and immediate aesthetics, something that obviously must be differentiated in clinical practice since the occlusal adjustment protocol is clearly different. But within that, anyhow, immediate loading is a key factor today. We live against the clock and it's necessary to offer the patient the most effective and reliable and also the least time-consuming treatment option. And of course, we also have to emphasize the great relevance that immediate provisionalization acquires for the patient, both from an aesthetic and a psychological point of view, for example, in cases of total rehabilitations or implants placed in aesthetic areas. Along these lines, and for the same reasons, it is also important to dominate the world of post-extraction implantology. A separate content will be dedicated to the issue of immediate implantology, so I simply remark here that this technique has evolved enormously in the last 10-15 years, and today it constitutes a reliable and predictable solution. And sometimes we do not only see it as a treatment option, but also as a duty and a necessary criterion for the final treatment outcome. So, well, in my opinion, it's such a dense and interesting topic that it deserves to be developed separately. And last but not least, the treatment of complex cases is perhaps our most distinctive feature. This is the reason why we work both with our own patient and with patients who are referred by other dentists after the diagnosis of a case that requires advanced surgical techniques, for example, due to the presence of a major bone defect or different degrees of atrophy in the jaw bones. And specifically, Dr. Alberto Vericat is the founder of our severe maxillary atrophy unit. The idea is that it's possible to treat even the most complex cases of jaw bone atrophy thanks to specific surgical techniques and thanks to the use of zygomatic implants. Zygomatic implants, in our opinion, and in the light of the long-term results of a large number of patients treated, constitute an excellent and reliable solution for such cases. Moreover, we think it's not only important to treat complex cases, but also to do that using the most reliable, simple, and least time-consuming technique. So we have the possibility to radically change the lives of these patients in a few hours. And we know that many have experienced enormous functional, aesthetic, and sometimes also psychological deficiencies. So I think this is one of the most fascinating and interesting issues in contemporary implantology. So, as I said before, I will treat it in a separate video to go into details about how we carry out the rehabilitation of such cases. So, let's begin by talking about predictable bone remodeling. Among the main factors influencing bone preservation, the concept of platform switching must be discussed. Several studies have already shown how it helps to minimize marginal bone loss, enhance the preservation of both bone and mucous papillae, and also contribute to an increase in soft tissue volume, something which in turn acts as a protection factor on the underlying bone layer and thus may avoid excessive marginal remodeling phenomena. And how is this possible? Well, over time, different hypotheses have been developed. It could be due to the increased implant crest distance, the connective tissue covering of the implant abutment microgap, or the Connor-Morse effect. But what really matters here from a clinical point of view is that a greater mismatch, a greater discrepancy in the diameters of the implant and the abutment, and especially a higher abutment, have shown lower degrees of bone resorption. And later we will also discuss which are the consequences of this concept affecting also the soft tissues. And of course, the one-time abutment concept, for us, it constitutes a categorical imperative since we never use the two-step surgery protocol. This factor is able to reduce both horizontal and bone loss and mucosal recession because we are talking about, as we will see, a deep subcranial area, a biological environment with a high healing, angiogenic and osteogenic potential. So the no removal of the abutment, the no breakdown of those mucous fibers and those hemidesmosomes gently attached to the abutment surface avoids altering the anatomy of that environment as well as its delicate biological balance. So consequently, the surgical technique is another key factor for the achievement of bone short and long-term preservation. First of all, the subcrestal positioning. The positioning of the implant you see in the picture, for example, that is the depth, that is the position we like. An ideal depth may be approximately 2 millimeters, but in our daily practice, if the bone quantity and quality allow us to do that, we prefer to position the implant to a deeper level, up to 3-4 millimeters below the crest, sometimes even deeper, for example, in cases of unfavorable post-extraction sockets or double cortical ridges. So, which advantages does this subcrestal positioning entail? On the one hand, it helps to protect the implant shoulder from potential future minimal bone losses, and on the other hand, it's linked to another key factor in the surgical technique, that is the absence of cortical tension. So thanks to the implant depositioning always being combined with a drilling of the cortical portion of the implant site, it is possible to minimize compression and tensions in that area and thus to avoid potential phenomena of ischemia and early bone resorption and necrosis. So what about drilling? Drilling must be adequate, unaggressive, minimally traumatic, especially in normal to compact bones. And let me explain you some tips about the drilling protocol in our implant system. Compact bone drills, which are parallel, non-conical drills, can be used or not, can be used at different depths or with a different diameter according to the bone density, but always must the cortical portion be prepared and left totally tension-free using a special drill, which is called pilot drill. And we must do that even in type 4 bones, in which obviously it's necessary to under-prepare the site, especially if a minimum torque must be achieved for the immediate loading protocol. And why is this possible? Because the primary stability doesn't derive from the marginal area, but from the apical third, thanks to the apical morphology of the implant we use, we will see. And I would also like to remark that always with the aim of avoiding any excess of bone compression, our maximum insertion torque is never greater than 35 newtons. And if after the first drilling the implant place is not as deep as we wish, we prefer to remove the implant, drill the site more with a compact bone drill with a larger diameter or at a greater depth, or even through an over-preparation if necessary, but we prefer this option rather than using a wrench or a greater insertion torque. Let's just take a look at a short video so you can see an example of the drilling sequence during a full arch rehabilitation. Now, let's talk about the features of both the implant and the abutment to understand how their features make it possible to respect all the above-mentioned key factors dealing with surgical technique and the preservation of hard and soft tissues. First of all, the implant we use is perfectly suitable for immediate loading protocols. You see here the morphology of the apical third of the implant, its aggressive threads, which helps to facilitate considerably the achievement of an adequate torque for immediate loading protocols. And moreover, it can do that independently from the marginal area, which results to be therefore protected from tension and overstress. So we can do what we like, which is immediate loading in the way we like, and that's to say, protecting the cortical area. Secondly, the implant has a totally treated surface with micro roughness from the apex up to the neck and even on the platform. The platform in this case is called bioplatform, and as you see in the picture, there's a groove on it. And this bioplatform has a dual function. On the one hand, thanks to the groove, it facilitates the adhesion of the blood clot, and on the other hand, it stimulates a certain degree of horizontal osseointegration. So, in addition to the classical vertical osseointegration, a horizontal bone formation takes place above the implant shoulder, thus improving the global bone-to-implant contact. So if we understand all these features, we understand how necessary it is for an implant with such design to be placed subcrestally. So this implant needs to be positioned at a deep intrabony level. And thirdly, of course, the abutments. First of all, the concept. What is the main advantage that these abutments offer us? Look at this X-ray, for example. This is a 2-year follow-up X-ray of a post-extraction implant. The socket was extremely unfavorable, presented severely compromised vestibular wall and septum, and on the day of the surgery, the implant was placed at that level, so deep, in order to result in a totally intra-bony position, thus taking as a reference the lower part of the bone defect. And then look at the abutment, that definitely high abutment. Why is it useful and why is its function so crucial? Because it allows us to compensate for the height discrepancy, that's to say the depth of the implant, and therefore to carry out the prosthetic rehabilitation at tissue level. And working at tissue level means doing it more comfortably, more easily, with a greater patient comfort, and without any trauma on the mucosa, thus allowing a greater tissue preservation. And moreover, it's possible at times to avoid regenerative procedures in case of atrophies, for example, of very narrow ridges, or major bone defects, for example, compromised or absent buccal tables, simply and precisely thanks to the possibility of placing the implant at an extremely deep subcrestal position and selecting a higher abutment to compensate the discrepancy and allow a comfortable prosthetic work. And then, obviously, the morphological features. We think that the morphology of the transepithelial components we use are extremely favorable. Everybody knows that the conical connection is the most effective one in reducing bacterial microleakage and allows a very good sealing to be achieved. And furthermore, the considerably concave and narrow morphology of these abutments contributes to a higher bone formation above the implant shoulder and around the abutment itself. And moreover, it allows per se to give the tissues a greater biological width, which entails and therefore leads to an excellent mucous adaptation and response. And one more concept. one could think, thin biotype, surgery, flap raising, I know a certain retraction will take place during the healing phase, so I better select a lower abutment, which the day of the surgery ends up being 2-3 millimeters subgingival position, in order to avoid, after the healing period, an excessively exposed abutment connection. Well, on the contrary, we think it's always necessary to choose the higher abutment that the soft tissue can admit the day of the implant placement, and even more in thin biotypes. Because these are high abutments and the fundamental biological width they create make it possible even for the thinnest mucosa to keep stable and healthy, thanks to the union of the hemidesmosomes and the biological sealing they provide. And obviously, all this wouldn't be possible without the above-mentioned abutment morphological features. So, after all we said, and in the last part of the session, let's take a look at some radiographs with the simple aim of observing the level of marginal bone after a variable follow-up period, 3 months, 1 year, 2 years, or 3 years. We will see only a few examples which represent an extremely wider case series whose results up to now are all similar. In some cases you will see orthopantomograms, in some others intraoral radiographs, some of which are part of a prospective study started almost 1 year ago, so they were carried out with silicone bite registration for reproducibility reason. But anyhow, I simply invite you to observe the bone level in the way we all do that when a patient comes to us for a follow-up visit, and we take a look at the peri-implant bone level to verify its conditions and rule out any kind of complication, right? So, for example, beginning with the 3-month follow-up cases, we can see a full arch rehabilitation of both jaw bones. The socket healing is correct, or better, the portion of the sockets which wasn't removed during surgery through the regularization of the ridge, which is also essential to anticipate post-extraction physiological atrophy. And the bone level remains emburied around each one of these implants. The same can be said of this other case, where we highlight the presence in the jaw of 2 previously placed distal implants that give us the opportunity to observe the different depth, the different concept, and the different image they provide. So personally, I think this image confers less security in a long-term perspective, and also know that the 4 anterior-inferior implants are 9 millimeters long, so despite the abundant bone availability, because we think it's not necessary to place the longest and wider implants the bone can anatomically admit. On the contrary, we do prefer a shorter but deeper implant with a higher transepithelial component, and this is another of our distinctive signs, and you will also see in other radiographs. And what do we see in these periapical radiographs? A minimal marginal remodeling after 3 months, and a bone level more than 2 millimeters above the implant shoulder. And the same can be seen in this other case, where the medial implant is a post-extraction one, and results to be approximately 4 millimeters subcrestial with no signs of vertical bone loss. The same in this lateral intraoral X-ray. I also emphasize here the satisfactory maintenance of the bony papilla, so important for the preservation of the mucous papilla, despite the fact that there is a certain proximity between the 2 implants. We now turn to the 1-year follow-up. We see that the marginal bone shows no variations, remaining 3 millimeters above the implant shoulder. And same image, bone level 2-3 millimeters above the implant shoulder. The same. Observe here, please, the depth, the height of the abutments, and the beautiful preservation of the bony papilla between these 2 post-extraction implants. When we place post-extraction implants with a flapless approach without carrying out any regularization of the crestal portion, we always like to place the implants into an even deeper position to protect them from that post-extraction physiological resorption that we already know will occur. Once more, the marginal bone remains 2 millimeters above the implant shoulder. However, we observe that the abutment here is lower, and the shape of the bone remodeling is slightly different, something that we also observe in other similar cases, and that does not prevent the bone level from being more than satisfactory. However, that's why we prefer to choose higher abutments, something which obviously is not possible in some clinical situations, as for example cases of limited interocclusal space. Now let's move on to cases with a 2-year follow-up. This is an intraoral X-ray that shows part of a superior full arch rehabilitation of an upper maxilla with an extremely low bone density. So hence the placement of a greater number of implants and the choice of a wider diameter. What's interesting to observe is the type of remodeling, the minimal and predictable, that has involved the marginal zone and the bone papilla, despite the inter-implant proximity. Another example, we see here a partial rehabilitation on 2 implants on the right mandibular side, one of them being a post-extraction implant. And again, we can see the level of the marginal bone that remains stable and after 2 years continues to perfectly protect the shoulder of the implant. And we can also compare this image to that of the section of the first quadrant, a treatment which is approximately 1 year older. The concept is similar, so slight subcrestal positioning, platform switching, but it's not as extreme as the one applied in the lower jaw. So I personally, of course, I find it very difficult to imagine how within only 1 more year the marginal bone in the mandible could show a resorption pattern similar to the upper one, since we have much more security, a bone margin which is much farther away from the implant shoulder. Another example on the right mandibular side. In this case, we can observe a small difference. These are 2 short parallel walled implants. In particular, the posterior 6 mm implant, due to the limited bone vertical availability in the posterior mandibular area, was positioned at just 1 mm subcrestal depth. And we can see that here the minimal remodeling of the marginal zone is somewhat more evident. So we don't have here the safety margin we like. Still, the implant is fully protected, and after 2 years the image is absolutely positive. The abutments in these cases are essential because they contribute to the maintenance of the soft tissue, which in this kind of cases tends to be quite thin and atrophic, and with it to the stability of the underlying ridges. Finally, let's see some example after 3 years of follow-up. We look at each one of these implants, for example, in this bimaxillary full arch rehabilitation, and we observe how no exposed threads exist and how bone remodeling has been totally predictable, so that the marginal bone is positioned above the shoulder of all the implants. The same marginal bone above the implant shoulder, or at most at the same level as, for example, in the 2 anterior superior implants which were placed at somewhat lesser depth the day of the surgery for bone density reasons. Last example, where we observe once again a totally predictable remodeling and 6 implants that after 3 years remain several millimeters in a subcrestal positioning. Well, reaching the end of this presentation, I hope you've enjoyed this content, and I guess you will be able to grasp some tips and concepts which may be applied in your daily surgical practice whenever the focus is placed on tissue preservation, since it's one of the most long-term success criterion we can count on. And I would also like to show you a few pictures of full arch final prosthetic rehabilitation, so that you can get an idea of the type of prostheses we work with and of the way we love to work it. So we know that this kind of rehabilitations allow to obtain great changes in these patients. By restoring a complete and aesthetic dentition, we allow them to recover function and also a good aesthetic of the lower facial third. And we can restore an adequate vertical dimension, a correct intermaxillary relationship, the lip support, the good profile. Thus, it's also possible to transform the global physiognomy of the face, and it's really impressive how this can produce a change even in the facial expression and the expressions of the patient's eyes. This is what actually constitutes the most intimate essence of our work and the main purpose of any implant surgery: to restore functionality, aesthetics, well-being, and sometimes also enthusiasm and self-esteem. So I let you see the pictures, the smiles, in this case series of before before and after, and thank you all for your attention. I hope you have a nice day and a good work.